Well, thanks a lot for the invitation again, Danny and the group. It's an honor for me to be here. I tried to make it personally and to spend some time in the Rockies, perhaps on a vacation, but medical circumstances prevented me from doing that. So I'll probably come and visit you a little later on this year if my health is okay. So. Thank you, Danny, also for the title of my talk, "Economist and Patient." What a great title! Yes, I'm an economist, and I've worked on healthcare for the Montreal Economic Institute, the MEI, over the past few years. And I think I have a few interesting insights on the problem. And I'm also a patient. I've been seeing the system from the inside for close to a year now. In fact, my wife and I saw the system from the inside for a while. My wife died 3.5 years ago from cancer, and it was a brief fight, a year and a half. Let's say that I was a spectator of everything that happened, and me personally, 11 months ago, I was diagnosed with pancreatic cancer, and I was given 6 to 12 months of life. And 11 months later, I'm still here and in pretty good shape. So I'm trying to beat the odds right now, and I think I'm successful up to now. So I'll give you first of all, a personal assessment of what I saw during the past few years in the Canadian and Quebec healthcare system. First of all, huge resources are used. For example, in Quebec, more than 50% of the budget of the provincial government is health and social services, more than 50%. So that's more than $1 billion per week that is spent in this system. In Alberta, the government spends 8% more per capita on healthcare than the Canadian average. But wait times are worse, in fact, than the average, than the Canadian average. And we are globally, each province is spending more each year, but results don't show. In fact, we're not progressing at all if we look at most indicators. So what are the problems? Where our system is overly bureaucratic, it creates bad incentives, it's replete with monopolies. Some things are getting better in the system. We have to I think, to recognize this. For example, palliative care is I think it's better than a few years ago. I'm in palliative care right now, and I can't believe the level of services I'm getting compared to my wife, for example, just a few years ago. Electronic files are much better than they used to be, but we're finally joining the 21st century. In fact, my doctors can take a look at my scans electronically. They're analyzed by one doctor, and the other doctors can see what's happening. So some things are improving, others are not. Wait times in elective surgery, amongst others, orthopedics, wait times in ER. For example, if we look at ER in Quebec, 1,000 patients per day leave emergency rooms before they see a doctor. 1,000 per day. So that more than 1,000 per day. So that's close to 400,000 per year. People who leave the ER without seeing a doctor simply because they've waited for 8, 12, 15 hours and they've had enough. They're not, let's say, in a bad enough condition for them to stay in the ER. My brother, who's an orthopedic surgeon, told me that he's 54 now, and he told me that his wait times for elective surgery will never recover from COVID. he'll retire. He'll be long retired, in fact, if ever they come back to what they were, and they were not very good. In fact, people waited for years to get hip replacement, for example. And generally speaking, COVID-19 has created new problems in the system, and these problems they show us that the system is not working. So, why are we doing so poorly? Well, and another question: why are the only choices the Canadian way or the U.S. one? And another question: is the solution more money? Well, in my opinion, there's a third way, and I'm not talking about Tony Blair here or Naomi Klein. In fact, I'm talking about something that's between what's done in the United States and what's done in Canada. And I'll give you some examples from developed countries. In fact, fortunately, a sort of third way already exists in Europe. In France, in Sweden, Switzerland, the Netherlands, Austria, Germany, they have a system that is universal, and that's much more efficient than the Canadian system. In fact, if we look at the numbers for Canada, we perform very poorly compared to other countries in the OECD. So that's the group of developed countries, about 40-something countries, and we're certainly in the lower third for most metrics, in fact. And that's not normal, because we spend a lot of money. We spend much more than the average or the median of OECD countries per capita. Okay, well, so what do we need? Well, in my opinion, we need four things. First of all, we need more decentralization of decision making. Secondly, we need more competition and less monopolies in our system. Thirdly, we need more innovation. And finally, we need more and better drugs, and we need to get them faster. So I'll be talking about these four, let's say, these four things that we have to strive for. First of all, more decentralization. We have the federal government that's mixed up in healthcare, plus the provinces. While the federal government's role is really financing the system and also creating rules for the system. The federal government should simply get out, except for a few items. For example, the federal government should continue running a drug approval for the whole of Canada to make sure that we have that drugs are available. The same drugs are available everywhere, and it should take care of things such as pandemics, which don't stop at provincial borders. But we already have provinces who manage the healthcare system. So the federal government should simply transfer the tax shares to provinces. And there's a simple principle in federalism here that's involved, and it's called subsidiarity. In fact, it's the simple idea that in a federation, the lowest level of government possible should take care of different issues. Well, the army, for example, that's certainly a federal jurisdiction, and it should be. Monetary policy, that's federal jurisdiction. The borders, but healthcare is defined by the Constitution as of provincial jurisdiction, and the federal government should get out of there. And there's a big problem with the federal government subsidizing the healthcare system, because we have one level of government that taxes the federal government, and another level of government that spends the money, and that's that's a good way to make sure that money is not spent well, and that probably too much money is spent also, simply because the government that spends the money is not taxing the people. So by transferring tax shares to provinces, as is possible in the Canadian Federation, for example, the Quebec, as I explained in my previous conference in Alberta, Quebec has obtained tax points in different areas, and in which it opted out. So the federal government should simply opt out of healthcare. Still on the topic of decentralization, well, the federal government more responsibility for decision making should be left to the people close to the problems. And that means hospitals, doctors, and all other groups that take care of people in the system. So we have a very, very bureaucratic system in which a lot of decisions are made by people on the top who don't know really what's happening. In fact, our system is very complex. It involves hundreds of thousands of people in Quebec, and it's the same thing in the big provinces in Canada. It's impossible for the minister on top of all this, the minister of responsible for healthcare, to know what's happening and to simply pull the levers of this big machine to make things happen. And we've discovered that with the pandemic, when we discovered, in fact, that very often the minister ordered some things, and what he ordered never happened, simply because, in fact, the chain of command was very complicated. And anyway, very often the decisions that were made by people on top were not the good decisions, simply because they were not well informed. So this is something that we've known for a long time, since it was put into writing by Frédéric Hayek, the great economist, the Nobel Prize winner, when he talked about the pretense of knowledge and also the use of information in society. So if a system is very complex, in fact, you have to decentralize decision making to make sure that the people who have the information, in fact, are the people who make the decisions. Secondly, we need more competition and less monopolies. And by the way, I'm talking about the problems, but I'll offer some solutions inside our system, in which, in fact, we have a lot of rules, and we have the Canadian healthcare law, which is, let's say, makes matters more complicated, perhaps, but it's still possible to navigate through all this. So secondly, the other thing that we need is more competition and less monopolies. So this can be done through hospitals and groups competing for patients. And here the private sector must be involved, and it's quite possible to do it. And I'll show you how just a little later on. So instead of having hospitals that simply take patients and receive an envelope of money to treat the patients, whatever the outcomes, well, you need to have hospitals competing for patients. That's why, in fact, we get good services normally in the private sector. When you're a client or a company, you bring in costs, but you also bring in income, revenue for the company. So that's why they want your patronage. Well, that's not the case for hospitals. Hospitals usually get a fixed amount of money, and should they have more patients and more satisfied patients, it doesn't change anything for them. So we need to have more competition inside our system. More competition means more entrepreneurship in our healthcare system. Government civil servants are not entrepreneurs, and they're not very good at that. So this means that we need the private sector to be involved. And in fact, one way of doing that is to have a private management of public or private assets in our healthcare systems. hierarchical system. For example, in Europe, and I'll talk about that just a little later on, you have a lot of countries in which you have either private hospitals or public hospitals that are managed by private companies. And you have entrepreneurs, people who innovate, in fact, who change things, who try to make things better. And simply because it's good for them, because they'll make more of a profit if they do that. And this is absent from our system, this profit motive. And in fact, we simply have a bunch of people who are civil servants, functionaries of the state, and well, we get the results that we get. More competition means measuring things. So provincial governments should be involved in measuring performance everywhere in the healthcare system. And that's something that governments can do. The private healthcare providers could do it also, but the government is still a big player here. A few years back, I went to a conference on healthcare. And one of the speakers at the conference was Philippe Couillard, who was the Premier of Quebec for 4 years. And he left the government before he became Premier. He started by being the Minister of Health. After that, he left the government to go into the private sector in healthcare. And after that, he came back as Prime Minister. He was not yet Prime Minister, so he was in the private sector when he spoke at the conference, and he was asked during a question and answer period what surprised him most from his time spent in the private sector, and his answer simply flabbergasted me. He answered that what surprised him most was that it's possible to measure things in the healthcare system, in hospitals. He was flabbergasted to discover that it's possible to measure how much an operation costs or a procedure costs. Well, if you have someone who's been Minister of Health for 4 years, and during these 4 years, he did not understand that it's possible and that it's important to measure things, well, you've certainly got a big failure. And I think that's a type of failure that's very frequent. That happens all the time in our overly bureaucratic system. A third thing that we need is more innovation in that means, first of all, managerial innovation. Changing the way things are done, the way things are managed, and here private firms are certainly best. And it's possible, as I said, to have private firms managing public infrastructure or private infrastructure, and this means that we need to have people who want to change the way things are done simply because they can find better, more efficient ways of doing things. Not more efficient in terms of pure profit, but in terms of better patient care, better patient satisfaction, and inevitably, in fact, profits will increase because their hospital or their enterprise will be in very high demand, and they'll be able to treat more people also. More innovation means more telemedicine. Telemedicine was a rarity in Canada before COVID, and it's not the case everywhere. In the United States, the Kaiser Foundation, for example, has been very, very active in telemedicine for a very long time. And I've done a study on that. I did a study about 10 years ago on this factor. So, for example, people who suffer from heart and lung problems, heart and lung degenerative diseases, very often have to go to the hospital 3 times per week in order to get their blood pressure measured precisely and to change their medication. While with telemedicine, these people can have simple equipment at home and can speak to a registered nurse, a very qualified nurse, every day, and have all the vital signs taken down. And if there's a problem, an ambulance is sent right away to take them to the hospital. And what was discovered is that with telemedicine, a nurse can see 2 to 3 times more patients per day. She can, instead of going to see the people at home, she sees them online, and people live longer and there are less complications. So in the end, it saves money also. Not only are patients better served, but money is saved. And we had to have COVID, in fact, to have some start of telemedicine in Canada, or at least to accelerate telemedicine, simply because we discovered, oh, wow, it's possible to have a medical consultation with a doctor, even without going to the doctor's office. And it's quite possible to do that. It's possible to have a lot of results given by phone, by internet, etc., etc. And also, more innovation means more out-of-province expertise and services. We import a lot of goods. We import a lot of services. Why don't we have, whenever we have long waits, for example, why don't we have scans examined by doctors in foreign countries? It's possible to have contracts with doctors who studied in the biggest faculties, the best universities in the world, in fact, and who live in different countries, and they could do this job remotely. And we do very, very little of that. We still have the impression that we have to do everything ourselves, and if it's not done by the government, well, it's some kind of sin, in fact, and it's not the case. A fourth thing that we need is more and better drugs. A lot of studies have been done on this idea, and I'll quote one of them. During the period 2000 to 2009, so a 9-year period, 73% of the increase in life expectancy in 30 countries was due to new drugs. So that's a result of one research, but there are a lot of researchers who point to the same general idea. So we've seen our life expectancy increase a lot, and drugs are responsible for a huge fraction, in fact, of that increase in life expectancy. New drugs reduce the cost of healthcare also. Whenever a new drug arrives on the market, it usually means less surgeries, less more invasive interventions, and this reduces the cost to the healthcare system. So this means that we need more drugs, we need better drugs, and we need more drugs in a more timely fashion. Canada is a laggard here. In fact, it takes years and years to get most new drugs on the market. And I have worked on this, and many other researchers at the MEI have worked on this problem. And I can certainly make available to Danny perhaps a list of certain researchers that are very interesting on the subject. It takes years and years, and we saw with COVID-19 that it's quite possible, in fact, to accelerate things without endangering the public. And we've seen that with the vaccines, for example. In a few months, we got new vaccines. Normally, the timeline for a new vaccine is years and years, and we did it very, very rapidly. Why are there such delays? Well, bureaucracy is certainly one part of the answer. I've been working on this problem with my friend and colleague Quentin Langley, who's right there. Hi, Quentin. And it has to do with the fact that government officials, ministers, bureaucrats face bad incentives. In fact, they will rarely be blamed if a drug takes a long time to get to the market, a new drug. but they will be blamed if there's a problem with the drug. So they're overly cautious. And during that time, well, costs pile on, people die, and we're not served adequately because we don't have timely access to drugs. So we need to shorten delays for drug approval, and we need to change the incentives in risk management of the production, in the risk management of the production of new drugs. There's another problem related to new and better drugs, and that's price controls. We control prices, drug prices in Canada to maintain them lower. Well, this reduces the number of new drugs that become available on the market and increases delays. So we have the impression that we're, in fact, saving money by controlling prices and drugs, by making them more or less expensive. But in fact, we might be increasing the total cost of healthcare. So if we want new drugs, and if drugs are really important for us, and I believe they are, well, we have to make sure that as much new drugs as possible come to the market. And for that, well, we have to reduce the disincentives, in fact, to innovate and create new drugs. So this brings me to the solutions. How long do I still have, Danny? About 5-10 minutes? Am I right? I'll proceed as if I have 5 to 10 minutes. One example of how things can be done, or some examples can be found in Europe. As I said before, if you look closely at how the healthcare systems in France, in Sweden, in Switzerland, in the Netherlands, in Austria, and Germany, and in other countries, if you look at the way they're run, well, you'll find major differences with Canada. So I'll take the case of one hospital in Sweden, in Stockholm, and it's called St. Goran. I'm not sure I'm pronouncing that correctly, though. It's a public hospital that was at the turn of the century, that was transferred, let's say the management was transferred to a private company called Capio, CAPIO. And public access was maintained, which means that when you are at the hospital, you give your healthcare number with your name. The government issued the number, and you'll be treated the same way in this hospital that's managed privately as in other hospitals that could be managed by the public sector. So there's public universal access. In some countries, people can buy private insurance, but everyone has to have insurance, and the government simply provides the means to people to buy this private insurance. In other countries, such as Sweden, well, people have universal access because it's from their taxes ultimately. So when you go to this hospital in Stockholm, well, you're not told that it's managed privately. It's like any other hospital. The hospital measures, because it's run by a private company and it wants to make a profit, it measures things. Contrary to what Premier Philippe Couillard thought. It measures internal, external indicators of performance. And it got this contract through a tender. And in fact, the tender was much lower than the public funding that used to go to the hospital in question. And after this company, Capio, started managing the hospital, well, in fact, all metrics showed that indicators improved. In fact, the results were better. There were shorter wait times. There were better patient satisfaction in the hospital, etc., etc. And they started, in fact, increasing the number of patients that they treated successfully, and happy patients also. So they treat more patients. Patients are happier, and it costs less money also. So if you add the three together, and you still preserve universal access, well, you've got success, in my opinion. So 4 principles were at work at St. Goran. Decentralization. In fact, the government in Sweden is not involved in the day-to-day management of hospitals. In fact, it simply publishes broad guidelines. It measures success or not. It measures performance. And hospitals can do as they wish to do the job. And at St. Goran, well, they've decentralized even further, in fact, given a lot more power to doctors to make decisions. They've given a lot more power to multidisciplinary committees and groups of people inside the hospital. They measure everything. And people in Canada would be surprised at what they measure. In fact, they measure everything. It's possible to measure most everything, in fact. They've created competition inside the hospital itself. And they've, in fact, created a set of incentives, of good incentives, to make sure that they make more profit. And they make more profit if patients get better, and if patients are satisfied. And so it's quite possible to do it. And on all metrics, in fact, St. Goran beats hospitals in other hospitals, public hospitals in Sweden, but beats. I don't think that any hospital in Canada comes close to St. Goran, in fact. And it's very simple. They didn't reinvent the wheel here. They simply decided to change the way hospitals were managed by in fact, letting the private sector manage hospitals, be in competition with the public sector, and the results speak for themselves. So these are things that are possible to do in Canada. The Canadian law prohibits private insurance in Canada, private healthcare insurance. It prohibits a lot of things, but it doesn't prohibit, as far as I know, the private management of public assets. It doesn't prohibit changing incentives, the way incentives are built in the system. It doesn't prevent breaking monopolies in the system. So there are a lot of things that we can do inside the healthcare laws in Canada to improve our system. And we don't have to copy the US. So a lot of people think that, in fact, it's either the Canadian bureaucratic system or a sort of imagined cowboy medicine in the United States. In fact, a lot of people imagine, in fact, the United States as being some kind of wild, wild west in terms of medical care. It's not the case, but we don't have to copy the United States. There are many flaws in the US medical system, and it's quite possible to get better results at much, much lower costs than what they have in the United States. And in fact, we simply need to look to Europe to have the proof of that, and to have examples that we could follow.